Hello everybody and welcome to this Take 10 video from IPC. My name is Claus Johansen and I'm from Department of Dermatology, Aarhus University Hospital in Denmark. And today I'm going to talk to you about precision medicine in psoriasis. So these are my disclosures. So if we look at a psoriatic plaque, you can see in this simplified schematic figure here that we know a lot about what is going on in a psoriatic plaque, what is driving the pathogenesis of psoriasis. And today we have a very good understanding of many of the cytokines which are really important in driving this chronic inflammatory skin disease. And based on this knowledge on the different cytokines involved in driving the disease, we also have developed a lot of drugs which we use in the treatment of psoriasis. We have the anti-TNF drugs. We have a drug targeting both the IL-12, IL-23 cytokines. We have drugs which specifically target the IL-23 cytokine. We have the IL-17 drugs, and we also have a drug which targets the IL-17 receptor subunit. So these drugs are highly used in the treatment of psoriasis, and they also work very well in many of the patients. However, we do still see some patients which do not respond to the treatment, or they lose their effect to treatment over time. So how do we treat psoriasis patients? Well, the average psoriasis patient is treated with what we call a one-size-fits-all approach. So with this approach, we often see that patients are with apparently the same clinical diagnosis or symptom exhibit different response to the same treatment. So if we have a group of psoriasis patients which have clinical diagnosed with plaque psoriasis, using this approach, one-size-fits-all approach, we will treat the patients with the same treatment, and some of the patients will have a positive effect of the treatment, some will have no effect, and some will even have an adverse effect of the treatment. So it would be really nice if we beforehand, before we start treating the patient, could predict which patients would benefit the most from a specific treatment. And this is what precision medicine is all about. So precision medicine, which is also sometimes called personalized medicine or stratified medicine, is an innovative approach for disease treatment that takes into account individual variability in genes, environment, and lifestyles, etc. for each individual patient. Therefore, the vision of precision medicine is to be able to predict more accurately the right treatment to the right patients at the right time. So again, if we have a group of psoriasis patients which have been clinically diagnosed with plaque psoriasis, using precision medicine, we could, for example, take a blood sample, a skin sample from the patients before treatment, and then these samples are analyzed, examined and analyzed, and based on specific biomarkers, we will be able to predict exactly which treatment each patient would benefit the most from, ending up with a positive effect for each individual patient. So what about precision medicine in psoriasis? Where are we as of today? So basically we are not that far, but there are a lot of studies out there, and I will here today show you some of these studies looking into precision medicine in psoriasis. So a number of studies have investigated the HLA-C0602 status and response to ustekinumab. And we all know that HLA-C0602, this allele is the predominant risk factor for developing psoriasis, and it is found in approximately 60% of patients with psoriasis. So recently there was a meta-analysis including 8 studies and 1,048 psoriasis patients. And in this study, they showed that there was a risk difference for achievement of, in this case, a PASI 75 response after 6 months of ustekinumab therapy, which was in favor for the HLA-C0602 positive patients. Meaning that if you are positive for HLA-C0602, you have a better chance of achieving a PASI 75 response by ustekinumab treatment compared to if you are negative for HLA-C0602. In this study, they also showed that the median PASI 75 response rate in the positive group was 92%, whereas this response rate was 67% in HLA-C0602 negative patient group. There has also been another study investigating the HLA-C0602 status and response to ustekinumab and adalimumab. And in this study, it was shown that if you were HLA-C0602 negative, you were significantly more likely to respond to adalimumab treatment than ustekinumab. This was seen at all time points, but most strongly after 6 months. This difference was greater in HLA-C0602 negative patients, which also had psoriatic arthritis. In this study, they also showed that biologic naive patients who were HLA-C0602 positive but negative for psoriatic arthritis, they had a significantly poorer response to adalimumab compared to ustekinumab at 12 months. So other studies have looked into single nucleotide polymorphisms in the TNF-alpha gene and response to anti-TNF-alpha drugs. We know that there are more than 200 variants of the TNF gene, and here today I will focus on 2 of these single nucleotide polymorphisms because they have been extensively studied in psoriasis. So in the first study, a specific SNP called TNF238 was assessed in a Spanish cohort of patients with moderate to severe psoriasis, including 109 psoriasis patients. And here it was shown that patients that carried the GLL had a better response to anti-TNF treatment, looking at a PASI 75 response after 6 months. In another study, a specific SNP named TNF857 was investigated, and here was shown in a meta-analysis including 2 studies and 177 patients that if you carried the CLL, you would have a better response to anti-TNF treatment. So overall, specific single nucleotide polymorphisms in the TNF-alpha gene can predict response to anti-TNF-alpha treatment. So another way of predicting a response to anti-TNF treatment is looking at the phosphorylation status of the transcription factor NF-kappa B. And this was what was done in this nice study back in 2021, where they investigated blood samples from 67 psoriasis patients before and during treatment with anti-TNF drugs. And they looked at the phosphorylation status of the P65 subunit of NF-kappa B, and they looked at P65 in type 2 dendritic cells that were induced by LPS. Interestingly, they showed that the phosphorylation status of this P65 subunit of NF-kappa B in type 2 dendritic cells before therapy was found to be an early predictive biomarker of response to anti-TNF treatment. This was seen at week 12, looking at a PASI 75 response. So it seems that you can not only look at of the genotype of specific genes in order to predict the response, but you can also look at other molecular markers such as the phosphorylation status of specific transcription factors in order to predict a response to treatment. So to summarize what I've been talking about here today, we now have evidence of useful biomarkers such as HLA-C0602, the TNF-alpha, and the phosphorylation status of NF-kappa B, which could predict treatment response in psoriasis patients. And many other potential biomarkers are currently being investigated as we speak. However, we must also say that these biomarkers are many of them are currently restricted to pharmacogenetics and based on single target genes, and therefore they are also far from being used in daily clinical practice. So I think that if we look at future biomarkers, these should probably consist of a panel of several biomarkers which combine both the phenotype, the genotype, biochemical molecular data from each patient in order to kind of personalize the treatment for the patients. And such biomarker panels would definitely be more reliable as compared to single target genes or only single biomarkers. And with that, I would like to thank you for watching this Take 10 video, and I'll see you later.